Good morning. Steve Stites, Chief Medical Officer, University of Kansas Health System, here with you again this morning. I am joined by a couple of great folks, in addition to my right-hand man here, Dr. Dana Hawkinson, Hawkeye. Man, I was going to go right to Doc Hawk from now on. He returns, and we'll talk a little bit about the goings-on here at KU. We're also joined by Chelsea Smith from the Community Blood Center. Chelsea and I want to have a conversation in just a moment about what's going on with blood usage, because we know that's really high, and we need to get back and get folks donating because we're getting dangerously low on our blood supply. So I'll turn to Chelsea in just a moment. And also joined by Lee Norman, Secretary of KDHE, a very good friend of mine. Lee and I go back a long way, and we're going to have a good conversation this morning about what's going on, what are the goings-on in Kansas. But first, Dana, how are we today?
Yeah, hey, how are you? We are doing pretty good in the hospital, 17 patients. So we've kind of saw a peak a little bit last week at the end of the week. 17 patients in the hospital right now. We have 6 in the ICU and 3 of those patients on the ventilator. We do have patients that are continuing in the drug trials for therapeutics against COVID-19. And I should say that even though, and we said this yesterday, even though our numbers have been stable, that doesn't reflect the amount of discharges that we've had and the number of new admissions. So we are continuing to get new admissions. But we've been able to discharge people, luckily.
So, which is always good news to discharge. Chelsea, I understand that. Let's talk a little bit about how short is our supply of blood in our community right now.
Yeah, it's pretty grim, to be frank. We always struggle. Memorial Day weekend is always difficult because people leave town, as we saw, and it cripples the blood supply. For usually that's a temporary thing. We bounce back that following week, but in a global pandemic, when people don't want to come in and donate, we've been basically struggling for the entire month. So we are still at a less than 2-day supply across several blood types. And as I mentioned last week, we like to have a 7-day supply. So that's cause for alarm. We're doing our due diligence to make sure that we're getting out in the community, where we have lots of opportunities for blood collection at our donor centers, at blood drives, but we're still not seeing the response we need to see in order to meet hospital need right now.
And you know, Chelsea, I think that the hospitals have increased and ramped up their surgeries. We're going back to both elective and emergent surgeries we've been doing, but the elective surgeries, some of which can use blood. We try to do bloodless surgeries here at KU, and I know everybody does as much as possible, but the inevitable truth is that you will need some blood around the operating rooms, and yet that blood is in short supply, which could endanger our ability to do surgeries in patients who really need them. So that's a really important issue. You know, we started off this program, it seems like a decade ago, but a few months ago, and we said BKC, and that was when we were getting ready and to pitch. We got to really work hard to flatten the curve, and Kansas City responded, our metropolitan area responded, and to the cries of a lot of people, not just this program, but BKC was one of our mottos. Well, I've grown up in Kansas City, and I know how giving this community is. I was here when the Hyatt Bridge collapsed back in the, I think it was in the 70s or early 80s. And when that happened, the line at the Community Blood Center was several miles long to give blood.
Yeah.
That's Kansas City. We need a BKC again, and our urge is for all of the metropolitan area to say, look, it is safe to give blood. It is safe, and we need you. To be bluntly honest, we need you. We need you to BKC. And just as we responded to that crisis and multiple other crises, because there was a long line after the Joplin tornado a number of years ago as well, we need a BKC again, because we haven't seen this big of a shortage in quite a long time.
Right. It's a lot different right now, because you're right. Kansas City responds incredibly well. They're very charitable. When there's a need, they step up. We saw the same thing for 9/11. There are people working at the blood center that were pulling overnight shifts because they had lines wrapped around our building after 9/11. And there are instances across, our history where Kansas City has stepped up and met this need, and we know that they'll do it again. It is weird. It's different right now because it's the danger is there. But we discussed this last week. Our blood drives, our donor centers are probably the safest places that you could be right now. We are taking so many additional safety precautions to make sure that you guys can come in and donate blood, and you're going to be safe doing that. So Yeah, it's a different kind of crisis, but a crisis nonetheless. So we're eager to see Kansas City respond.
We need you. We really, really need you. And I don't think the threat's going away, Lee Norman. Yesterday, the state of Kansas ended up opening up everything after a lot of pressure from the legislature and others. Talk to us a little bit about what you think that means and what's the status of COVID-19 in the state, and do you have any predictions for how things are going to go?
Yes, and first off, thanks for the invitation. It's
We're
always nice
delighted to have you back. Anytime, you're welcome. You're welcome. I think you owe me dinner still, if I remember. Maybe I owe it to you. I'm not sure which way that goes, but it's out there someplace.
No, I'll leave the influenza season to you guys, which is really going to be important, by the way, this year. We want to make sure that everybody gets immunized when that time comes. Well, Kansas, first off, the reopening metrics are all going the right direction when you look statewide. The disease spread, there's still a lot of COVID-19 out there. There's still positive cases, especially as we ramp up now, more and more testing being done all the time. But the disease spread is still improving, and hospitalizations and death per capita are improving. So the reopening plan was working, I feel. I think that the fact that Governor Kelly did the early school closures and the early stay-at-home orders bent the curve more than anything else. And the actions by the legislature last week really, in many regards, derailed what the reopening plan was doing. And now, instead of having a statewide executive order that dictates what the county by county would do, it leaves it up to the individual counties, and it's going to be highly irregular from one county to the next, and it's going to be very confusing. And I don't think people do well with confusion. In reality, we have two kinds of counties in the state of Kansas. We have counties that things are bad and counties that things are pretty good. And we only have about 8 or 10 counties that are the problems, and you know what those counties are. They're the ones with meatpacking plants, the larger urban counties that have a fair number of skilled nursing facilities and prisons. The rest of the counties are relatively spared and getting better all the time.
Yeah, so this is going to be an interesting challenge to us, and we'll have to track it really carefully. Do you think that there's any chance that if things really got worse again, we could go back into more of a restricted situation?
I think there definitely could have backtracking that would require that to be done. There's some, and I hate to even go through this because it gives me such a headache. The legislative action taken after the session ended, I might add, will be challenged legally. It's probably even an unconstitutional event that took place since this legislature wasn't in session. And what Governor Kelly and her administration says, the emergency order, the emergency declaration must stay in place in order to get federal funding, in order to have the strength to do the things we need to do around the state. But allowing the stay-at-home and reopening plan to sunset then lent a lot of confusion. So the emergency declaration is still in place. That allows us to buy, distribute PPE, distribute remdesivir, all those many things that you've seen us doing from a state level. We've distributed $53 million worth of PPE to healthcare facilities and
yes,
first
and we've
responders.
been some of the beneficiaries, and thank you.
Yeah, and and that would go away. We have 543 service members, Air and Army Guard, that are helping with this. That would go away because the money comes from someplace to hire those people, and so the emergency declaration has to stay in place. The legislature comes back on June 3rd for a special session. I'm just a doctor. I'm not a legislator. We'll see how that goes.
You're a doctor now that you have to have a political stripe too. I don't have to have
more than I
can
want.
Just be a doctor.
More than I
doctor.
want.
Yeah, that's
me.
right. Well, let's turn to our media and see if there are questions that they would like to start us off with this morning.
Good morning, gentlemen. I do have a question. It's Cindy from KCTV5. Those little oxygen meters are like flying off the shelves these days. Do you think that those are as good or better indication of somebody who may be asymptomatic as it will tell, like if your oxygen level has dropped?
Wow, Dana, we can all three take a crack at this. I'm not a fan, but you start first.
I think there's several questions in there. So the first question is, what do you think about the handheld pulse oximeter, which is just a simple device that goes on your finger, and it's able to, through light, determine the amount of oxygen in your blood. And certainly Dr. Stites and his pulmonary colleagues use them all the time for various reasons. I think for home use, it's okay, but it's certainly not recommended to people regularly get them unless it's been prescribed by your physician for one reason or another. Say you have underlying lung disease or something like that. I don't think it's necessarily bad to have one and get one. Typically, I would think if your oxygen was that low, you probably would not be one of those people who are the asymptomatic group. Overall, I don't have a inherent problem with them. But you have to be careful what kind of information you're trying to get from that as well.
Yeah, here's the problem. You got to know what they mean and how they operate. Yeah. The first thing is that unless it's picking up your pulse correctly, then the reading it has is absolutely meaningless. And if you don't know how to measure your pulse to verify that the pulse number on the oximeter is tracking, then you shouldn't use it because the device will be meaningless. The second thing is there are multiple things that affect your oxygen level. If you sit there and you don't take a deep breath for a couple minutes, yeah, your oxygen level goes down. If you're asleep, your oxygen level goes down. If you get a little chest cold, your oxygen goes down. If you have asthma or COPD or emphysema or any other of a number of health problems, your oxygen level may go down. Is it going down because of COVID? Look, if your oxygen level starts to drop because of COVID, you're going to be short of breath. That is not an asymptomatic issue. And so as a result, there should be other signs that point to it. So does an oximeter really help you manage COVID-19? No. If you want the information to scare yourself, okay. But the reality is, unless you know what you're doing with an oximeter, I would really be cautious about its use. Now, that's my strong statement. As a pulmonary guy, that's how I view it. And I have a lot of patients who have oximeters at home, and sometimes they cause us a lot more trouble, and they make people panic and have fear when they don't need to. Often because the results aren't accurate. How much fingernail polish do you have? Well, that's going to affect it. How long are your finger? That's going to affect it. What did you have for dinner? That could affect it. So there's so many things that can affect this. You just got to know how to use the device. Lee, anything else that?
No, nothing to add. I think that sums it up.
We're unanimous today. Other quote. Did that help you? Other questions?
Yeah, and again, I think with those devices, just as anything, even with masks that we've had in the hospital that were, essentially medical grade that we actually had to take back, you have to be careful. Who is the manufacturer? Is it valid?
Is it
anyways?
accurate? Gosh, again, if it isn't measuring your pulse accurately, this how fast your heart rate is. And they've got a little measure on there to tell you how fast your heart rate is. If it can't measure that, it can't accurately measure your oxygen level. And so you got to know how to validate the instrument.
I might add one thing, a more general comment, and that is that I probably get 30, 40 solicitations per day on pulse oximeters, on PPEs, on gloves from shysters, essentially, that are fraudulent antibody tests. And I've been unfortunately having to work with the Attorney General's office to go out after some of these people. So I think the consumer really wants to read the fine print. Make sure there's FDA approval or emergency use authorization, because there's a lot of people that are being taken to the cleaners with these devices and drugs and whatnot.
We've said that we're still a little skeptical, although less than we were, about the antibody testing, in part because of what we think is the underlying prevalence of COVID-19 in the public, and second, or SARS-CoV-2 in the public, and second of all, because of the sensitivity and specificity of antibody testing. What's your sense from the state level, and how soon do you think it may be ready for wider application?
I think it's ready for prime time now, as long as it's the right device and the right test. We are this week putting in the antibody platform that is highly sensitive and specific for COVID-19 antibodies. We're going through, starting tomorrow and early next week, the validation process of that antibody test. And I think it'll help us. The way I think about it, we test and look for disease, but we also do prevalence studies. And I think the antibody test will help with the
prevalence.
Yeah,
exactly.
And that was, matter of fact, that was when I got the Attorney General involved early on, was because there were some places around the state where antibody testing was being done, and they were given bad information. The patients saying, "Oh, there's an antibody, so you can go take care of patients, COVID-19 patients, without wearing any PPE," for example, and that is bad idea. So what initially I brought up as a fraudulent selling on the part of the this test maker. I also had to bring over from a consumer protection basis was they were given information that was not even valid.
Right, and because we also don't yet even know what an IgG level means in COVID-19. Right. We think it's good. We don't know how preventative it is. So, all right. Other questions from media? So let's jump to some of our public questions, and I have a list. Jill has a list. So Jill, do you want to start, and then we'll go back and forth?
Can the state mandate masks in essential businesses?
Okay. Dr. Norman, that's yours.
The state, I think the short answer is no, except to say that there is statute that allows, for example, me, to shut down an unsafe business. If there are public health practices that are being violated and it's inherently an unsafe business, then I have the statutory authority to close that business down. The county health officer does too, and I can overrule the county health officer if that person chooses to not do that.
Dana, a lot of questions have popped up about masks. What do you think about whether you can actually reuse a mask, especially a cloth mask?
Yeah, I think we've always said that you can reuse a cloth mask. We have certainly recommended that you maybe have 3 or 4 so that one can be in use, one can be cleaned, one can be in stock, and you can change between those things. It certainly also depends how long you're using it for. But I think that is probably the best practice, is to have multiple masks so that you can wash them, or if you buy it from a commercial seller, adhere to the cleaning guidelines so that you can have one on your face, one in storage, and one being cleaned, and you can just rotate through those.
And what do you think? We're still asking our inpatients to wear a mask.
We are, yep. So luckily, here we have great practices with all of our healthcare workers wearing masks and eye protection, but we are also asking our patients to wear masks when they have patient encounters with physicians or therapists or anybody else who may be coming into the room.
Yeah, so we really, that's a big stress, and we stress that all our healthcare providers and people throughout our hospital, we all wear masks out there now. So
yeah, and I think, we also, when we touched on this last week, we are testing all of our preoperative patients prior to coming to surgery, 1 to 2 days before. We're also testing all of our inpatient admissions now. And this is done for many reasons, and this includes, we understand that there is such significant now asymptomatic or pre-symptomatic spread of the virus. Certainly 1 to 2, if not 3 to 4 days prior to any symptoms. And now obviously the CDC last week put out about maybe as much as 30 to 40% of people are asymptomatic. So this knowledge changes as we get the original experience from China to our experience here. We are learning that it is so important because we understand you can have very high viral loads, viral titers, and be spreading the disease without even knowing you have the disease.
One of the things that we get asked, and you guys should both jump on this, but if a person has no issues that is known with their immune system and they've recovered from COVID-19, assuming that then their antibody test would be positive, would they ever even need to wear a mask? Because I'd still say yes.
What do you think, Dr. Infectious Diseases? No, I think that I still think that there's other good reasons to wear a mask. I would understand if a person thinks that because they have an antibody present, that it necessarily means they're immune, but I don't know that we necessarily know that.
We don't know the answer to that. Not really, because we haven't had accurate antibody testing to look at large populations and see how true it is.
I think that, throughout forever we've known that antibodies are protective, but that does not necessarily mean that we know that they're immune.
Right, and it doesn't mean that you couldn't reacquire it and give it to someone else.
Right. Yeah. Well, and the other thing, and Dr. Hawkinson will weigh in on it, that we don't know that there's just one serotype of the coronavirus. There's other viruses where you can be immune and have antibodies against one of the serotypes, but not necessarily to all of them. When this virus is so new.
We call that influenza.
Yeah, that's right. Dengue, a few others.
Dengue fever.
Yeah, actually, right now they thought, well, are there 2 different major types of the virus from China? And originally, it looks like, for the most part, if you look at the genome level and if you look at those phylogenies, which are just basically like family trees for viruses, it seems like the virus probably hasn't had too many base mutations in the genome, maybe 15 to 20. For really hasn't changed too much. Certainly not the mutations we would think of for influenza. So as we get further out, we'll know more about that stuff. We have some good evidence from a rhesus macaque study, which we use rhesus macaques, the monkeys, as the animal model now, which is very good as we go through more vaccine and drug trials to fight COVID. We can use that as a very good model that show, maybe you aren't getting the same disease when you have reinfection with COVID-19, so that's very promising. But is it a milder? What is the amount that you're still shedding? We still don't know that in humans. Should you come back into contact with it, you would hopefully have protection in either no disease or mild disease, but we don't understand that for sure, and we don't know how long that protection would last. Is it 12 weeks? Is it 6 months? Is it 9 months? We hope you would, but I think there is still that concern and that ability to even shed the virus should you be reinfected, even if you are COVID recovered.
All right.
How do I know if I'm buying a reputable mask?
Buying a reputable mask. Okay. Well, that's a hard one, isn't it? So.
Well, I can tell you what we do is that we look and see the manufacturer and what their reputation is, because a lot of these are coming from China, interestingly, and are not being acquired and purchased locally, which I think says something. But the second thing is that we test them. For example, we ordered 500,000 masks, but I got a prototype from them first, and they, without getting into too much in detail, a score should be 100 or greater in terms of its efficiency, and this was 5 to 10. So I mean, I've not jokingly said I wouldn't even think it would make a good coffee filter, let alone a good mask. So the reputation of the manufacturer, and then if you have questions, you can test them.
One of the things that pops up as we kind of change gears a little bit, do we have stats that, Dr. Norman, especially that compare COVID-19 infection to death rates to the flu or cardiac arrest or cancer? I think people still sometimes struggle about whether COVID-19 is really deadly or not, and why are we so terrorized by it?
Right. Well, we do have all those records. Matter of fact, the Office of Vital Statistics, which may not sound very exciting, is in my agency, and we review every death certificate that gets before it gets recorded for any of those things, but especially for COVID-19. We've even gone back to coroners and attending physicians at times saying this is listed as a COVID-19, but given the information we have, is that really the case, or was that had they recovered from it and they died of something else? So we do go back and try to back validate to make sure that the statistics, it's a highly lethal disease. I mean, it's going to be common, and it is common, and it may not, on a case fatality rate, it might not be as high as other things, but there's going to be, and there continue to be, a lot of deaths, as you saw from these numbers that we're hitting in the United States.
Well, and yesterday, at some point during the day, we passed 100,000 deaths, and the New York Times on Sunday published the names of 100,000 people who had died of COVID-19. A flu season typically is around 20,000 or so. Auto accidents in a year is 30 or 35,000. The Korean War and the Vietnam War together, I don't believe, had 100,000 deaths, or they were right around that. And we're going to bypass that. If you think about that, the scope of it is quite great in 1 year. And I think what's terrorizing about it or scary about it, you may not know when you're sick, or you may not know when other people are sick. And it's because of the rapid spread of the pandemic and its potential to overwhelm the health system and our ability to help people recover, it became even more of a scary thing than that. In terms of cancer or trauma, this is really not those are like apples and oranges in terms of what kind of cancer you have, in terms of what kind of trauma you have. But it is of the infectious diseases that are active in the United States. I dare say, Dana, this is the one that should scare us the most because of the number of people who are dying from it. And it is much scarier than influenza. We have treatment for influenza.
Yeah, absolutely. And we have to understand influenza is, 6 or 7 months long? We'll say September to April, shortening it a little bit even. And you had just as many deaths. But what have we had in 3 months with COVID? And that's 100,000. And those are the deaths that we know about that were caused by COVID. In addition, influenza, we see a lot of deaths. And certainly in 1918, they saw a lot of deaths because of secondary bacterial pneumonias. We aren't really seeing that to the high propensity that we see with influenza. We don't really see that with COVID right now as far as secondary infections to that extent. And so we really have to hammer home that this is not influenza. And if it takes anything, hopefully people will understand that now who are still calling this a bad influenza. It is much different. It's apples to grapefruits. It's very, very different than influenza for that.
I think folks want to find safety, and they want to minimize the seriousness of the disease to help them justify going about a more normal life. And I do understand that. It is frustrating to have to not be able to go out to your favorite bar or restaurant or hang out or go out and watch. You guys all by now know I'm a sports fan, the Royals and Chiefs or sporting or KU basketball or what have you. Those are hard things. We want to be able to go down to the lake and party, and you want to be able to go out into public and feel safe. And the way we then try to make ourselves feel safe is we minimize the threat and we say, well, this is nothing more than a bad influenza. Except that it's untrue. And at some point you have to accept the truth. 100,000 deaths in the United States, an advanced country with a great healthcare system, 100,000 deaths in 3 months. That is not influenza. And if you think that it is, honestly, you're just not being honest with yourself or your friends or family. And that's our challenge. It's what we want to have happen, what we want to believe against what is true. And there's sometimes we should depoliticize debates and just recognize what is true. Because lies aren't going to change this disease. You just have to understand this is not influenza. It's much more deadly. And it's also much more sinister, because you don't even know when you're sick, and you may not know when others are sick. That's very different than influenza. I've been a doctor for, approximately a very long time. I've taken care of a lot of sick folks with influenza. I've taken some folks who died from influenza. COVID-19, that's not influenza.
What is the actual mortality rate or survival rate?
What do you think?
Well, it's a little hard to know that because there's so many cases that we don't measure, but I think that the case fatality rate is probably in the 1% to 3%, and maybe even lower when you increase the number of asymptomatics, so maybe 0.8%. What do you think, Dr. Hawkinson?
Yeah, I think I saw 1 to 0.5, which is still, 10 or 5 times the influenza infection fatality and case fatality rates. So, and again, I think we have to understand that, when this first started, the initial flurry of information came from China. That was their experience. And then we got a little bit from Japan and South Korea, and then, of course, Italy. And I think our experience here is just a little bit different based on different things. Socioeconomic factors, demographic factors, geography as well, and the inherent problems or inherent issues within each specific geographic region within the United States, in addition to certain clusters, whether it be employment places or nursing homes. So we don't really have a good idea for that now. All of these extrapolations are just made on the data that we have in it. Overall, it is probably lower than we initially thought, and it's probably, I saw certainly, again, 0.5 to 0.8, certainly under 1. Hopefully that's a good thing. The problem is even that small number, when you have so many infections, whether asymptomatic or symptomatic, that can add to a lot of volume.
Yeah, there was a population study done in Iceland that was pretty good, and it supported those numbers. The way I think about it when I'm asked I say that probably around 1 out of every 167 cases. I think that's something that people that may not be statistically inclined can certainly understand. That out of every 167 people, one person is going to die.
And that's of total cases. It's different because that's not the same thing as testing, because we believe there's a lot of people out there who have it that never get tested. So if we change that on its head a little bit and say, how many people will die out of the number we test? That's even a different question, because that'll look lower. Well, I don't want people to be reassured and say, oh, my risk of death is 1 to 167, but that's if everybody who has the disease and not just those who get tested, because it's higher if you've been tested.
We're getting a lot of questions about returning to work and travel. I want to share 2 examples and then have you doctors weigh in. One is a 60-year-old woman who's concerned about going back to the classroom. Another is a woman who doesn't say her age, but she has Hashimoto's. She has to travel. She has to get on a plane twice, have a layover, has to train 12 people, and she's not allowed to wear a mask.
Oh, boy.
Should she cancel her trip?
Okay, Dr. Norman.
Should she go back to school?
Let's look at the travel restrictions first for the state of Kansas. Does the change in events yesterday change the travel restrictions for KDHE?
No. And to that end, our KDHE website is really quite good, and we have the travel restrictions because it's always changing. For example, Colorado was just taken off the list where you had to be quarantined upon coming back into the state. I think in answer to those questions, Jill, is that there's probably no specific guidance that says yes, you should go to work, and no, or yes, it's fine to travel. I think people have to use their best judgment and apply the principles. I think the classroom is going to be probably more safe than it would have been. Because we haven't talked about schools yet, but the classrooms this fall and winter are not going to look like what they were in the springtime at the time of adjournment. There's going to be lots of engineering changes. There's going to be schedule changes. And I think the woman can probably, with protective measures in place, feel okay about that once it's safe to open. I think the travel one on airplanes, layovers is a different one.
And you can't wear a mask and you have to teach 12 people in close quarters.
Right.
I mean, if you have any health problems there, I'd say, oh, that's just not a good idea. What about, Lee, students? Will they have to wear masks at schools?
I think it would be unlikely to have that as a recommendation. The matter of fact, just yesterday, the Kansas Department of Education has asked us to join them in putting together the guidance for this upcoming school year. We want to get that out we want them to, and as well as the Board of Regents and Higher Ed, to come out with some strong recommendations early on so people can do their planning.
Yeah.
But it'll be up to the local school boards.
Right.
You know, when you look at jurisdictional issues, it's not KDHE and it's not the Department of Education. It's the local school boards. So there'll be a lot of variability, I'm afraid, which will make it confusing. But we want to provide as best guidance possible.
Dana, your thoughts around the question of traveling and airplane travel, because we've taken kind of the approach that, man, there's always a risk to life, and then there are the benefits, and you just have to decide which way to go. But if someone is concerned about their health and has to be on a plane with a layover and in front of people, I don't know, that spooks me a little.
Yeah, absolutely. You know, certainly I would be concerned about in the plane. It's much more confined. The layover in the airport, if you can avoid the high-touch surfaces, if you can continue to safely, physically distance yourself, wear the mask. Again, we heard the story about the Ebola and the HIV researcher who had tackled those viruses and was researching and had been doing that for 40 years, who was on a plane, and he thinks he got it from plane flight. So his best guess was that maybe he got it through his eyes because he had a mask on. He was doing perfect hand hygiene. So that's the other thing, is with a mask, do you want to wear glasses or something of that nature? Obviously, we've said that glasses are not eye protection, but maybe they would offer some in that instance. And then I would be concerned more about the enclosed space where you're teaching 12 other people and then none of you can wear a mask. I don't know what the spacing would be, how large the room is. Is it a gymnasium or is it a tiny classroom? That's what I would be most concerned with as well.
Yeah, those are hard
Viewer
ones.
says you skipped over the Hashimoto's part. They want you to talk about that a little bit.
Okay, Hashimoto's.
So I don't.
Can you repeat that part of the question again? Because
Well,
I'd
the
really
person had it. People are concerned about, does it give me Hashimoto's? If I have Hashimoto's, am I more at risk?
Right, we addressed this to Doug Girard, who's the chancellor of the university, but also an outstanding ENT surgeon and an ENT surgical oncologist, really helped us address the Hashimoto's 2 days ago.
You know, I think if you have Hashimoto's, it is probably and most likely not in the same vein as if you have underlying malignancy, chemotherapy, lung disease, heart disease, diabetes. I don't think there's really an increased risk there of just having the Hashimoto's disease itself. The question was, well, can it cause it? Well, maybe getting COVID can unmask it. We certainly know that COVID can cause various inflammatory processes or inflammatory dysregulation in the body. But so could it occur that way? Sure. But just having a diagnosis of Hashimoto's, I don't believe puts you at any other greater risk than someone who doesn't, especially compared to those other comorbidities or diseases I talked about, especially diabetes, heart disease, and lung disease.
Chelsea, you're hearing a lot about masks and things like that this morning. Talk to us about some of the things Community Blood Bank is doing to make sure donors stay safe.
wearing masks inside our donor centers and inside our blood drives. Additionally, we are doing temperature checks at the door. There's hand sanitizer everywhere. We are disinfecting disinfecting every surface after a donor touches it. So basically, we're following donors throughout the entire process with disinfectant wipes and making sure that it's clean for the next donors to come in. We're maintaining social distancing, so 6 feet apart on all of our chairs, 6 feet apart if you're waiting in a line. People can wait in their cars if there is a wait. And then we're also operating mostly on an appointment-only schedule at our donor centers and our blood drives. We do have the capacity right now, because we don't have as many donors as we need, to allow for walk-ins sometimes. But if we, for some reason, have a full appointment schedule that day and there's a walk-in that comes in, we have to evaluate capacity and safety at that time. So strongly recommending appointments, but we can take walk-ins on a trial basis for right now. But yeah, we've been doing this since March began. We've been implementing new protocols as CDC has come out with new recommendations. In the beginning, people weren't wearing masks, so that is something that we've implemented in light of that. But we're monitoring CDC guidelines every day, making needed changes as things come up. But yeah, we're doing our best to make sure that these places are clean and safe and controlled environments for donors to be able to come into.
Yeah, good news. And Dr. Norman, I don't think we've seen any outbreaks in a community blood bank, any contact tracing.
No, we've had about 100 or 105 clusters and outbreaks that we've investigated, and about half of them are inactive now. I was openly critical about what we saw from the Lake of the Ozarks.
Yes.
Over the weekend, the first week of the month, we had a similar kind of party cove environment and lashing together of boats at Lake Perry. There's been now over a dozen cases of that in multiple counties and in 3 states. And I'm sure that will keep on keeping on. So people really have to be vigilant and not let their guard down at this point in time.
And isn't that really the story of COVID-19? If we're careful, we're going to be okay. It's if we're not careful that things start to break down.
Well, I really think that and I agree, Steve, I think that we should not accept the fact that wave 2 is necessary in our country. Because I think that we can attack it and can continue going after it and not have the assumption that is how pandemics act, and it has for hundreds of years. We know
Right.
that. But I don't think that we can have to necessarily just roll over and say, okay, come on, let's have wave 2 and we'll do the best we can. I think we should be working to prevent it.
I mean, one of the struggles is how do you keep the state open and get people back to work and yet stay safe? What's your advice for people that have to go back to work? I mean, we hear this question a lot. Is it safe for me to do this? Is it safe for me to do that? What advice do you have around that? You've investigated 105 outbreaks, I think, in clusters. So what's your advice? What have you learned that can help keep people safe?
And to that end, and what you just said, we're getting a lot of camping, wedding.
Right. It's all the same question. How can I stay safe, really?
You know, it's understanding the principles and not trying to mindlessly follow and skirt around rules. There are people that want to find a rule and then find a clever way to skirt around the rule just because they can. That's the wrong idea. That's the wrong attitude. People understand, and you guys have been talking the principles so religiously about distancing and about mask wearing when you can't control the environment you're in. You have to assume that person is infected. They have to assume that I'm infected. And just the hand washings we've just hammered and hammered away on. These are not random recommendations. These things work. It's why and I'm sure, Dr. Hawkinson, you've talked about the R0 and the infectious factor. We've been very successful at pushing that down dramatically. So embody the principles and stick with them. Don't let your guard down.
And I think you can't create your own reality, Dana, that says this isn't severe. It's not like it's no worse than influenza. We'll all be okay. I mean, that's not a reality. Yeah. That's somebody trying to create their own reality so they don't have to follow the rules. Mm-hmm. That's what gets us in trouble.
Yeah. Yeah, absolutely. I'm glad you mentioned the R0, or the reproducibility value. So we think that the R0 is generally 2 to 3 for this disease. So
explain what R0 is.
So that is when a person has it, how many people can they infect is the basic thought about the R naught. And so if I have it, can I give it to 2 or 3 people? So that is about the same as influenza or so. One of the most virulent or easily infectious viruses is measles, where that is airborne, and that has an R naught about 19. Well, what we think, certainly...
But one person's going to infect 19 others.
Right, because it can just hang in the
air. And we
air.
call that really bad.
That is really bad. Luckily, we have a very good vaccination for measles, so we should all be up to date on that. But what they've also found in one of these cluster studies from China, when they talked about asymptomatic people, and again, it could be 30 to 40% of people that are asymptomatic. So generally, it's also younger people. I think the median age was 37. But in those cases, because they think a lot of the spread came from the asymptomatic patients, so that R naught jumps from a range from anywhere from 5 to 25, with really a point R naught of about 18 or 19, so the same as measles. So that's why it just hammers home the fact that you could have the virus, you could be pre-symptomatic, meaning before any symptoms occur, or asymptomatic, meaning without any symptoms, but you can still spread the virus. And you are probably more important for spreading the virus, such as similar to a super spreader, than somebody who actually has symptoms.
And I think that's really the focus, this is why we ask people to try and stay safe all the time, because there are vulnerable people around us, and many of them are our friends or loved ones. We want you to stay safe, and we want you to help keep others safe. As an ICU physician for many years here, I had my 5 rules. You guys have heard me talk a little bit about them. Number 1, save the patient. Number 2, do the right thing. Number 3, do no harm. Do no harm. It's in the Hippocratic Oath. It's in the Oath of Geneva that physicians and healthcare providers take before they go to practice. And it says you're going to take the best you can of your patient, you're going to try to help them, and you're not going to harm them. We have to adopt that to each other. We have to not do harm to each other. And the way we do that is we follow the rules. And the rules, they're a little hard sometimes. And until there's effective vaccination and effective therapy, those rules really aren't going to change, Lee Norman.
Right. I've been doing a series of videos for kids and answering their questions, and it's just been fascinating. And one of the things that I've kind of charged them to do within their household is to kind of be the hallway police. And when their siblings or their parents,
we call them my middle child in our house.
That's right. We all have one of those.
Yes, we do. I love you, Sierra.
And that's and it's been fun because I put fun in quotes because some of the parents are coming back saying, "You've made my kid even more annoying," and because their hallway monitor saying, right. you just came in from outside, you didn't wash your hands. You have to wash your hands. Mm-hmm. What don't you understand, Dad, about not washing your hands? And it's been very successful. And I think, for example, even we're here, sitting here without masks on, but we're great. We're following our rules.
Mm-hmm. We are 7 feet away.
We know how many air exchanges there are here.
Yes, we do.
We know how far the distances apart.
Yep.
We're not symptomatic or coughing and sneezing. So we are in the embodiment of these rules. And I got my temperature check
when I walked in this morning.
Yeah, so as did I. And so I think it's really a matter of embracing your own preparedness. Mm-hmm. You are responsible for your own preparedness, and I think that's what people need to do.
It really is. And my son would say that that he had 2 moms, my wife and then his sister. And James has turned out to be a wonderful human being. I'm not sure which one of these 2 would my wife or my daughter would take credit for that. Probably both.
All right, we have a question that has to do with when will we know about the therapies that are being tested? Mm-hmm. And then do you doctors have a single source that you go to for keeping up with therapies and drugs? A person is looking for one place where they can go and get all their
one place for information, and how do we look at that? So and this will be our final question today, and then we'll wrap up.
Okay. Well, I think there are many sources. I would always go to the CDC website. They may have information about therapies. Certainly, I believe it's clinicaltrials.gov also has ongoing trials. The other places you can go, certainly if you have a subscription to UpToDate, which is used by a lot of medical providers. For the general public, I think it's just a matter of getting those websites down and understanding those. I'm not aware really of any other specific things. Certainly if you can go to the medical journals themselves, they may have updates as well, things like New England Journal of Medicine.
In the New England Journal of Medicine, I believe you can access the coronavirus articles without a subscription right now.
Okay.
Yeah.
So those are probably the main things that we use here in the health system and the medical providers use. And I don't know if there's any other public information out
Dr.
about
Norman,
that.
what do
You know, here's my suggestion, not Facebook.
Correct.
Anything else
Yes, I
is
agree.
better than that. One of the things that I did when we saw this unfolding and we set up incident command at the state was I brought aboard one of our former state epidemiologists, Charlie Hunt, and the Kansas Health Institute that wanted to provide some benefit to us. And what I have them doing is constantly researching best practices and what's new. I don't think there is one source, but I think you can bookmark. I think you can go to the internet and find 5 or 6 and bookmark them and visit them frequently. Mayo Clinic Proceedings has things that are for patients, I'm sorry, for the public. So I think, and maybe what we could do is, in a future one, do some of our homework and have some of our people provide some
answers to that.
and bookmark these 6 or 8 sites, and it'd be really beneficial, I think.
I think Hopkins, and my two go-tos are the Johns Hopkins website. I think KDHE is pretty good. I'm just going to give you all a shout out. You guys do a good job. And I would also say CDC. You know, the CDC has this part of it, the Morbidity Mortality Weekly Report. That's really good, and I think most people can get it, and they have a public-facing portion of it that's really good. And so I would really recommend you go to the CDC website because what you really want is things that are being fact-checked. The problem with Facebook and Instagram and Twitter, whatever, none of those things are fact-checked. And so people just push stuff out and they say what they want and may or may not be true, and it may have a lot of other motivations behind it. And that's where we run into trouble. It's sometimes those other motivations. But I think that the CDC website is good. Is it 100% accurate? No, because none of us, we don't know 100% about coronavirus. And so nothing is perfect. But I think it's really apolitical, and I think it's just trying to tell you what people know, and it keeps you pretty up to date. So if you really want to go look at the public-facing part of the CDC website. I think that's where I would go.
Steve, and to that end, I didn't toot our own horn probably enough. The KDHE website has a COVID-19 mini site within it. So
it's really good,
and there's a lot of tabs, and we
link to the CDC a lot. I mean,
right, and we pull in those articles. We're a clip service essentially that's bringing in CDC stuff, and then but we refresh it every day. Yeah. We've got editors.
That's why I was trying to touch your horn because you weren't.
I was on it this morning.
KDHE does a really good job. You guys should be proud.
It's got maps and graphs and charts, and it is a good site. Thank you.
Yeah. Let's wrap up today. Chelsea, I want to turn to you and ask, okay, final messages. I think I know what it is. We're on the same website, the same website, the same page here about we need blood.
We do need blood. We do. We understand leaving your house is a little bit scary right now, but we want to assure you that we're making our donor centers and blood drives as safe as they can be. And we also want to assure you that the need is real and your community needs you to come out and donate blood immediately.
And we've seen the Hyatt Bridge. We've seen the Joplin tornado, 9/11. We need a BKC. We need you, folks. We just need you right now. And help us carry that message to get it out there. Dana?
Yeah, just 2 quick things. You know, we have to remember there are no FDA-approved therapies or vaccines right now for COVID-19. There is an emergency use authorization for remdesivir, which looks like it may help people recover and be able to go home a few days sooner. But even remdesivir is still under trial. All these drugs are still under trial. There are many trials still undergoing. Hopefully, and this changes very quickly, hopefully we'll start getting this data back on therapeutics. The other thing is Dr. Norman mentioned about the pillars of what to do. We have broad recommendations. You know, we've always said stay 6 feet or 8 feet or 10 feet away. Be outdoors if you can. Do the hand hygiene. If you can stay with those pillars and put those into the context of what you may be doing, that is probably going to be how it's going to help you make your best decisions on risk versus benefit. Should you be doing this activity? Should you not? And certainly wearing a mask out in public is very important as well.
Dr. Norman.
Last, one thing I did want to emphasize, and I should have said it earlier, the reopening plan is no longer embodied in an executive order, but we are still marching ahead with it as if nothing has changed, in the sense that we're bringing the best data in and the best recommendations and are still providing those to counties and anybody that wants them. So we are full steam ahead with the same plan to provide the high quality information so that the county by county they can make their best recommendations and requirements.
Chelsea, thanks for being with us again. BKC, we need you. Dr. Norman, thank you so much for being here today. Thank you. And Dr. Norman, thank you again for being here. It's always good to have you around.
Thank you very much.
And have you here.
Awesome.
We'll welcome you back anytime, and always Doc Hawk. And to all of our listeners out there, do the right thing. Do no harm. We'll see you tomorrow.